Good morning, everybody. This week is World Asthma Day, and the last couple of years we've had the pleasure of hosting a speaker, and it's truly a privilege this year to have Dr. Stephanie Lovinsky Desir be our speaker for Grand Rounds. She is Herbert Irving Associate Professor of Pediatrics in Environmental Health Sciences and the Chief of the Pediatric Pulmonary Division at Columbia University Irving Medical Center and the Morgan Stanley Children's Hospital of New York Presbyterian. Dr. Lovinsky Desir completed her residency in pediatrics at the Children's Hospital of Montefiore in the Social Pediatrics program and a pediatric pulmonary fellowship at New York Presbyterian Columbia. Her research really is focused on understanding how environment impacts children with asthma, particularly in urban and minoritized communities. Dr. Lovinsky Desir's work has been funded by the NIH, the Robert Wood Johnson Foundation, the Health Effects Institute, and other foundations. She recently served in the EPA Clean Air Scientific Advisory Committee as a member of the Particular Matter Panel. She is currently serving on the EPA's Children's Health Protection Advisory Committee. Dr. Lovinsky is an elected member of the Society for Pediatric Research and is very active in the American Thoracic Society, where she served in multiple capacities within the Pediatrics Assembly and is currently the vice chair of the ATS Health Equity and Diversity Committee. In addition, she's a spokesperson for the American Lung Association. Welcome, Stephanie.
Thank you, Dr. Celadon, for that kind introduction. Good morning. It's so great to be here. Is my audio okay? You can hear me okay? All right. So as Dr. Celadon mentioned, Tuesday was World Asthma Day. How many people actually knew that it was World Asthma Day? That's okay. That's why we're here today, so that we can celebrate together. And the idea behind World Asthma Day, this is a day that's named by the Global Initiative for Asthma. It's really to get people to start thinking about more about what asthma is, what it does, how it affects people, and put a little bit more emphasis so that we can really address what's happening with asthma. In our cases for children. And so this year's theme is Asthma Education Empowers, Information is Key. So I'm here today to provide some information for you all. So I'm going to start with a little bit of background. I did my pediatric general peds residency training in the social pediatrics program at the Children's Hospital in Montefiore, where I met Huron way back when. And we did social peds was really focused on understanding the communities, the environments, the neighborhoods, and the settings in which people live, particularly children, and how that impacts their health. And so part of our training included some dedicated time to spending time in the community. In my first year as an intern, I did a walking tour of the South Bronx, which is the neighborhood where my clinic was and where many of the patients that I cared for in clinic lived. And when looking at this environment, just kind of walking around, they had recently introduced a floating pool to the neighborhood, which you see here. There were a lot of parks and green space. And I was like, oh, this is a lovely neighborhood. But then I started walking a little bit more and learning a little bit more. So that yellow arrow represents those parks that I showed you in the last picture. Each one of these red circles represents a waste transfer station. So that's an actual facility where garbage gets brought into. And then those little S's there represent all the schools that are in this teeny tiny little neighborhood community of Hunts Point. And currently in New York City, 80% of the waste transfer stations are in 3 of the poorest neighborhoods, one of them being the South Bronx neighborhood, Northeast Brooklyn, and Southeast Queens. And as a result of all of this traffic from garbage, diesel trucks passing through these communities, 1,400 of them every single day. So you can imagine every single day how many diesel trucks are passing through this tiny, tiny community. And it may come as no surprise that this neighborhood in the South Bronx of New York is a neighborhood that has some of the highest asthma prevalence and the highest asthma morbidity, 3 times higher asthma death rate in the Bronx compared to other communities in the state. And so this like opened my eyes because I thought, you know, where a child lives, the neighborhood and the community surrounding them really has an influence on their quality of health, the quality of the air that they breathe, and their potential to have future disease. And so that is really the idea about environmental justice, right? The color of your skin or the thickness of your wallet shouldn't determine your ability to breathe clean air. And I think this is when I kind of become awoken to this concept and really drove my passion to go into pediatric pulmonology and really study environmental justice. When we think about environmental justice, it's defined as the fair treatment and meaningful involvement of all people, regardless of race, color, national origin, or income, with respect to the development, implementation, and enforcement of environmental laws, regulations, and policy. So I have 3 main learning objectives today. I've broken up today's talk into 3 sections or so, maybe 4. But the main goals here are to understand historical factors that contribute to disparities in social and environmental determinants of health. And then we'll talk a little bit about how social and environmental determinants of health contribute to asthma prevalence and morbidity. And at the very end, I'll identify some areas that we think are likely to have an impact on reducing asthma disparities. So I know not everybody in this room is a pediatric pulmonologist. So to orient you all, we'll briefly talk about asthma. You know that there's both a chronic component and an episodic component to asthma. So you see on the far left there, a picture of a normal airway. In a child who has asthma, that airway is thickened and a bit inflamed. And then if there's a trigger, they're having an asthma attack or an exacerbation, it becomes further constricted. There's tightening of the smooth muscles around those airways. And there are several well-known, well-identified triggers and risk factors for both the development of asthma and the triggers of asthma exacerbations or asthma attacks. So allergens this time of year, you may be seeing in your clinics, lots of kids coming in with itchy eyes and itchy noses, and that's exacerbating their asthma. Respiratory infections, change in weather, having an 80-degree day next to a 60-degree day can also be a trigger for a child's asthma. Environmental exposures like tobacco smoke, air pollution, obesity, exercise, and we know that asthma tends to run in families. Disparities also exist in childhood asthma prevalence across the United States. So here's a map on the left-hand side here that shows you the current prevalence of asthma across the US. And you can see in my state in New York, we have some of the highest asthma prevalence, as high as 8%. In your state of Pennsylvania, there's also really high asthma prevalence. And I think a lot of this often gets concentrated in urban communities, urban settings. So in Philadelphia and Pittsburgh, I think the prevalence of asthma might be much higher than it might be in some other rural areas. But the other piece that's really important is that asthma doesn't affect all types of people similarly. So if you look at this graph on the right-hand side, you can see American Indian Alaska Natives and Black, non-Hispanic Black individuals and Hispanic individuals have some of the highest rates of asthma, up to 3-fold higher, 2 to 3-fold higher than non-Hispanic white individuals. And you can see there's a breakdown here between Hispanic overall, Mexican, and other Hispanic. I'll show you more on the next slide. Your very own Juan Celadon has been doing some work teasing out, you know, even among people who identify as being Hispanic, the prevalence of asthma is not necessarily uniform. And, you know, these disparities have existed over time. This isn't a new phenomena, or this isn't something that we're getting greatly better at. I mentioned Hispanic populations being unique. Puerto Rican, people of Puerto Rican descent in particular, have some of the highest asthma prevalence. And you can see that this disparity, although there's been a slight improvement in trends over time, the disparity still persists compared to white individuals, non-Hispanic white individuals. And then I think maybe even more strikingly is not only is the prevalence of asthma discordant or disparate between groups, but the morbidity is also really disparate. So, when you think about asthma mortality, in 2020, non-Hispanic Black children had 7.6 times the death rate of asthma compared to non-Hispanic white children. So it's not just that they're having more asthma, they also have really bad asthma, And so what are some of the factors that contribute to this? So let's talk a little bit about the past. How did we get here with these disparities in asthma morbidity and asthma prevalence? So we cannot have a talk about disparities pretty much in any topic without acknowledging the historical, structural, and social determinants of inequitable distribution of environmental exposures. And this includes the displacement of Indigenous Americans. This includes the history of enslavement and segregation of Black Americans. And this includes the disenfranchisement of Latino Americans. This is where it all starts. And as a result of this historical context of marginalization of certain populations of individuals, we see that it contributes to social discrimination. And that includes racism and caste, which is the unequal treatment of individuals and communities based on race and ethnicity. This leads to both segregation within our communities and our neighborhoods, which I'll show you a little bit more about, and really segregating poverty. So really keeping people in lower socioeconomic status situations. And it leads to social stress. And as a result of that, we see disparate sources of exposure. This is in the neighborhood structure and the locations of where people live, where they work, where they go to school, and how they commute to and from school. Now, when I originally put this figure together for a manuscript that Juan asked me and some colleagues to write, I had racism in class, and that was before I read Isabel Wilkerson's book, Caste. Has anybody read this book or seen the movie? Ava DuVernay has a movie that's out at some streaming platforms. I highly recommend it. It's called Origin, The Nature of Our Discontent. And so what Isabel Wilkerson describes in her book is this concept of caste, which is a fixed social group into which an individual is born within a particular system of social stratification. And this Pulitzer Prize winning author says caste focuses in on the infrastructure of our divisions and the rankings, whereas race is the metric that is used to determine one's place within that. And so the term is more precise than race because it really is comprehensive and it gets down to the underlying infrastructure that we often can't see, but that is undergirding much of the inequity and injustice and disparities that we live with in this country. And if you think about it, it's not that long ago that these signs were everywhere. And someone like me could not go to the same restroom as many of you in this audience here. That is caste. That is the social, structural systems that are put into place that are meant to divide people. And here in the United States, we use race as a distinguishing factor to place people into different castes. So what is racism? I like this definition from Braveman et al. Racism is the relegation of people of color to inferior status and treatment based on unfounded beliefs about innate inferiority, as well as unjust treatment and oppression of people of color, whether intended or not. Racism is not always conscious, intentional, or explicit. Often it is systemic and structural. I like to read books. I mentioned that last night. And so I have another amazing book for anybody who really wants to dig in deep and understand a little bit more about how our cities, our neighborhoods, and our communities have been built off of this caste and racist structure. And so in this book, that's by Richard Rothstein, he outlines how government-sponsored policies and programs contributed to segregated inner cities, or what have been termed ghettos, where mostly Black people, but also some newly immigrated Latino families live. So for example, he talks about the institutional practice of creating segregated public housing, He also talks about historical redlining at that, and I'll talk a little bit more about redlining that barred individuals who lived in mostly Black communities from getting mortgages. The Housing Finance Administration, or the HFA, that refused to insure new mortgages and new constructions based on who the intended occupants were of these buildings. He talks about restricted covenants, or the provisions that were placed in deeds of home that explicitly stated that a home could not be sold to a Black person. Blockbusting techniques of realtors that instigated white flight from urban communities, a more recent housing market crash that resulted in subprime mortgages that were mostly marketed towards Black Americans, exclusionary zoning laws that maintained white suburbs, industrialized poor Black neighborhoods, and introduced point sources of pollution such as highways and industrial sources within some of the poorest communities in the United States. Okay, so how is this affecting children today? Let's talk a little bit about the present. So as I've alluded to in this discussion, proximity to traffic sources, proximity to industrial sources, unfavorable housing conditions, as we kind of described earlier on, all of these lead to both outdoor and indoor sources of allergens, environmental pollution, and things that we know, and I'll talk a little bit more about, that contribute to asthma and allergic diseases. But there's this whole extra layer in addition to the environmental exposures, but there's this whole layer of social determinants of health, which we've been hearing a lot more about lately. And that's factors like the neighborhood and the built environment, social and community context, economic stability, education, access to good quality education, and healthcare access. So all of these things are not only associated with environmental air pollution, they are associated with asthma and allergic diseases, and then they interact with these two. So it's very complex, but there's a lot of data here. And we also have to talk about stress at the community level and at the individual level. That plays a significant role on various factors here. So our group recently took a look at waste transfer stations and bus depots in New York City. I alluded to this in the very beginning, that waste transfer stations introduce a lot of point sources of air pollution into neighborhoods and communities. So I have two maps of New York City here, one on the left that shows you the percent of people of color, with the darker areas representing neighborhoods that have higher percentage of people of color. And on the right, you see percent below the federal poverty level. Again, the darker areas represent neighborhoods with higher people. And so the triangles there, if you can see those yellow triangles, represent the active solid waste management facilities, and the orange circles represent the MTA bus depots. And I'm sure you can appreciate here that those bus depots and waste transfer stations tend to be in the neighborhoods with higher percentage of people of color and higher percentage of people below the federal poverty level. Let me see if this works. I like to point out this neighborhood here. This is in Queens, which is a neighborhood where I live in. And you see that we have a high proportion of people of color, although it's not necessarily a high poverty neighborhood, but we bear a disproportionate burden of these point sources of traffic pollution. And this isn't just in New York City, this is across the country. This is a paper by Tessam and colleagues that really illustrates many different sources of fine particulate matter exposure. So you can see in the red, those sources that have significantly higher impact, versus in blue, the sources that have lower impact. And what you can see here is for pretty much all of the different sources of pollution, people of color are more impacted. So they have greater sources of air pollution within the neighborhoods within which they live. And it's really important because we know that air pollution is associated with asthma. We know that air pollutants are involved in airway responsive gene pathways and antioxidant gene pathways. We know that air pollutants interact with allergens in the type 2 pathways to lead to sensitization and asthma. And we know, as I mentioned before, that air pollutants are a trigger or are known to exacerbate asthma. And this comes from a recent statement from the American Thoracic Society. It was a workshop where they summarized the evidence related to air pollution and asthma. And they demonstrated that there was strong epidemiologic evidence for childhood asthma and long-term air pollution exposure, included traffic-related air pollution, nitrogen dioxide, and black carbon, which is a component of fine particulate matter. They also highlighted the mechanistic evidence that shows biologic plausibility and to airway remodeling that comes from these pollutants. And they came to the conclusion that long-term environmental air pollution is a significant cause of lung function deficits and the development of childhood asthma. I actually had the privilege of working with a colleague, Matt Perzanowski, at the Mailman School of Public Health at Columbia, who was doing a project looking at neighborhoods across New York City that had higher asthma prevalence and lower asthma prevalence. And what you can see from this map is that we have some neighborhoods in New York that have asthma prevalence as high as 18%. And oftentimes those can be right near other neighborhoods that have really low asthma prevalence. So Matt was trying to figure out why. And I took some of those data and I looked at some of these neighborhood level characteristics within these higher versus lower asthma prevalence neighborhood, and saw that the higher asthma prevalence neighborhood had a greater percentage of Black and Latino residents, fewer white residents, greater poverty, more people on public assistance in crowded housing, fewer people who had graduated from high school, and greater point sources of pollution. So we talked a little bit about historical redlining, and I'm sure nowadays, if I gave this talk about 3-4 years ago, most people weren't as familiar with the term as they are now. But as was mentioned before, in the 1930s, this was after the Great Depression, and the idea was try to invest in communities and neighborhoods as part of the New Deal. And so the government-sponsored Homeowners Loan Corporation was created in order to figure out where should mortgages be granted across neighborhoods in the United States. And so what they did was they created these maps, and they were trying to determine perceived risk for mortgage lending, but they used racial composition of the neighborhoods to decide which neighborhoods they would invest in home mortgages. And so as a part of this decision of prioritizing where they would invest, they actually systematically limited wealth generating opportunities based on these discriminatory practices. And it's really, as I mentioned before, perpetuated racial segregation, poverty. It's influenced where highways and other point sources of pollutants have been placed throughout a community. We took some of these data from, this is publicly available data from the Mapping Inequality Project, and we put it on a map looking across New York City. And so hazardous or redlined, these were the neighborhoods that were deemed the least, the neighborhoods that they did not grant home mortgages in, versus the other neighborhoods definitely declining, still desirable, and the best neighborhoods, and we group those together. And you're going to be very familiar with maps of New York City by the end of this talk, so here you go. Here's another one. And so we looked down on the top here, you can see that redlined neighborhood map, so those red neighborhoods that were color-coded, and we looked at 3 different pollutants. I mentioned black carbon, which is a component of particulate matter, and nitrogen dioxide. And I think you can see again here, this overlap between the neighborhoods that were historically redlined and the neighborhoods that have the darker color or the highest concentration of these 3 pollutants across the city. And you know, we had a paper a few years ago that reported that air pollution concentrations had been declining across New York City. And this is thanks to many legislative changes that had happened in the city over the last few decades. And so one of them is New York City's Clean Heat program that was launched in 2010 to eliminate diesel-based fuels to heat residential buildings. So we decided to look at this data set and see how pollution concentrations looked between 2009 and 2018 over this 10-year period. So the good news is air pollution concentrations going down by 2.6 to 4.4% annually. The problem is that not all neighborhoods are experiencing this decline at the same rate. And so you can see those red circles represent the red line neighborhoods, the dark circles represent the other neighborhoods. And by and large, the red line neighborhoods still have significantly higher air pollution concentrations. So even though we have laws and rules that are meant to improve air quality, they're not implemented necessarily in the neighborhoods where the people are most at risk. And so we see declines, but we still see disparities. We looked also at the social vulnerability index, which is a metric to see vulnerability within a community that might be at risk. Similar graph looking at the childhood opportunity index, which is another index to try to understand neighborhood deprivation and potential for potential risk. And in the historically redlined neighborhoods, they had higher or greater social vulnerability. They also had greater density of truck traffic exposure than the non-historically redlined neighborhoods. My dear friend Nita Thacker published a paper in 2020 that similarly looked across neighborhoods in California. And she looked at historical redlining. I took some of the data from her paper to create these figures and demonstrate again that across these neighborhoods that were historically redlined, that's the peach color there, the grade D neighborhoods compared to the other neighborhoods, there were significant disparities in terms of the people in California who lived in redline versus non-redline neighborhoods. There was significantly greater poverty in the historically redlined neighborhoods, and there was more point sources of diesel pollution in those neighborhoods. And Nita actually looked at asthma emergency department visits across both adults and children in historically redlined neighborhoods. And I mean, you guys know what a dose response curve is, right? Where you see an increasing dose and an increasing response. This is essentially a dose response curve that current day, present day, people who are living in these communities today that were redlined over almost 100 years ago are still experiencing greater emergency department visits for asthma compared to those neighborhoods that were not redlined. So we just submitted a manuscript. It's actually in revise and resubmission phase as part of the Muppets 2 clinical trial from the Inner City Asthma Consortium. Now it's called the CAUSE Network, or the Causes of Asthma in Urban Settings. And this parent study, it recruited children from 9 cities across the United States. You can see pictures of these cities here. And what we found in this study that hopefully will be published very soon is that children who either lived or went to school in historically redlined neighborhoods had a stronger association between environmental air pollution exposure and both reduced lung function and worse asthma severity scores. So this will be the first paper that really looked at the link between historical redlining back almost 100 years ago and current sustained impact on the lungs of children living in these communities today, 3 to 4 generations later. And if you're curious about your own neighborhoods here in Pittsburgh, I just pulled, last night I was randomly on this website. The EPA has this great new tool that's called the screening, the EPA Climate and Economic Justice Screening Tool. And it's a map-based tool where you can just click on it, type in either a zip code or a neighborhood, and it spits out information so you can identify if the neighborhood where the individual lives is considered historically disadvantaged. And so I just pulled up, I don't know Pittsburgh geography very well, but just looking at this map, I chose to highlight the Garfield neighborhood. And I don't know, I can see if anybody thinks that this was a good choice, but you know, I picked it because when you look at it was considered one of the neighborhoods that had historic underinvestment, meaning it was a historically redlined neighborhood, and it happens to have a really high asthma prevalence in the 94th percentile of national asthma prevalence. Also has pretty high diabetes and heart disease and low in the 95th percentile in terms of overall life expectancy. And you can compare this to the Highland Park neighborhood that on the map looks like it's not that far from Garfield. That was not historically underinvestment. Asthma prevalence is in the 50th percentile and similarly low on some of these other metrics. So, there are many of these mapping tools out there, and I think a lot of research is moving towards how to implement these into electronic health record systems so we can identify our patients as they come through our door and determine what are some neighborhood and social factors that might be contributing to disparities in their respiratory outcomes. And so I want to talk just a little bit about this interplay. We sort of alluded to it, but just to map it out a little bit more clearly for you here. So, we talked about community level stressors and buffers that are in the built environment and in the social environment that lead to point sources of pollution where they're located, area level contamination, and overall community level exposure to things that cause people to have worse disease. And then this is also related to individual level stressors and buffers. So that includes chronic exposure to individual stress as well as individual allostatic load. So allostatic load is defined as the wear and tear on the body that accumulates due to chronic stress that may suppress immune function and increase the risk of disease. And so Arlene Geronimus, another book, I should have a book list to share with you of all that came in here. So Arlene Geronimus wrote a book called Weathering, and she basically describes this process of allostatic load and this phenomena of the effects of this. She basically says that, it's not necessarily how individuals care for themselves, but it's more about how society treats us that really leads to health and aging and overall deterioration. So this is this concept of stress and how it influences. I was talking a lot about telomeres and shortening of telomeres and how that influences overall health. But that individual allostatic load has the potential to impact the internal dose of air pollution exposure, the response and resilience of the body to air pollution, the health effects, and then the overall ability to recover from these environmental insults. So a colleague of mine, I mentioned Nita Tucker, she also recently published this study looking at adverse childhood events, ACEs. I'm sure you guys all talk about ACEs in your general PEDS program. And so she looked at an allostatic load score. So all of these listed parameters that were pulled together into a comprehensive index to create what's called an allostatic load score, and compared that to adverse childhood events. And what she found is that if you had scored positively or reported at least 1 to 3 ACEs, those children in her study had a 1.4 greater allostatic load. So this is happening in children, that we're seeing that environmental exposure, stress, and all of these factors combined are influencing our metabolic pathways and leading to potential increased risk of worse disease. So we have another workshop report that is just about to be published that was produced at the American Thoracic Society and sort of to kind of put this all together. And the title of this paper is The Impact of Historical Racialization and Systemic Racism on Asthma Disease Prevalence and Outcomes. And what we describe here is that there's geographic origin, ancestry, colonization, all of these factors that lead to a perceived phenotype or phenotypic differences. And what has happened is that this has turned into historic racialization, leading to policies and structures that are implemented to uphold this racist caste system. And as a result, you see in this center box here, when we talk about systemic racism, we're talking about current socioeconomic and political context. We're talking about social caste, which I described a lot about, talking about socioeconomic position, and these factors all feed into or lead to contextual factors. And, we spent a lot of time talking about systemic racism this morning, but even at the bottom here, you can see interpersonal racism, prejudice, and bias also play a role here. I didn't even talk about what happens when our patients come into our exam rooms or they walk into our healthcare systems. How are they treated? How do they feel when they're in this system? And how much of that prejudice and bias also influences their health. And all of these factors, both systemic and structural racism, as well as interpersonal racism, feeds into the biology that leads to asthma disease prevalence and disparities in health outcomes related to asthma. That was a lot, right? So now you're thinking like, oh my God, that was a ton. That feels so heavy. And I absolutely hate ending a talk on such a like heavy note of like, it's all bad. It is, it's bad. But we can fix it, right? Like there's some things that we have the power to actually do something about. Every one of us here has the power to do something about this. And the model I propose to you here is related to asthma, but I bet, you know, in your day-to-day and whatever discipline that you spend the most of your time in, there are also opportunities of ways that we can actually influence this. So what can we do about it? So these steps come from a paper from another colleague, Monica Federico, who wrote this paper looking at pragmatic steps for clinicians to address social determinants of health and environmental justice. And she mapped out sort of 3 broad areas of where we can actually put some work in to really address environmental justice. So first is thinking about working with patients. And this includes things like shared decision-making. You know, really, we often spend a lot of time focusing on like stressors and things that cause disadvantage within home and social environments. But we should also think about amplifiers and what are some of the things that sort of prop families up and keep people supported, and how do we enrich those things? Using clear and simple language is really important. Connecting people to resources and screening for modifiable social determinants of health. It's our job, if these are factors that are influencing health, to actually screen for them and really help people to address them. So I like to nod to this awesome program in New York City that's called the New York City Healthy Homes Program. I'm sure there are similar programs here in Pittsburgh. This one is run by the New York City Department of Health, and it's a referral program for children who have asthma, who have environmental exposures to mold or pests in their home. And basically in the clinic, as I'm screening a patient, I'll ask, do you have mold exposure? Do you have pest exposure? Somebody says yes, it's, do you need some help with this? Most of the time people are like, I've been begging the landlord, they just paint over the mold, or they don't really clean up the cracks. And I make this referral, and they actually, a New York City Department of Health worker comes into the home and actually helps. And I've had so many success stories of this program really influencing people's lives and really making a significant difference. And so I implore you to think about, speak to your social workers and community health workers about what are the resources within your community and the communities where your patients live that actually might help them, rather than just documenting that these issues exist. Another example is thinking about air quality. So I talked a lot about air pollution exposure. You all know what the air quality is today because it's all on your phone, and your very own Francisca Razer is doing a lot of great work looking at the air quality index and figuring out how can we make sure that this is useful information for us to share with our patients and our patients to know about. So I tell my patients, particularly as we're moving into the summer and we know that high ozone days and air quality tends to be worse, particularly if there are wildfires raging, you know, I'll tell patients, you know, open your phone, look at the air quality, scroll down as you're trying to decide what to put, whether or not to put on a jacket today, look to see what the air quality is and use that to help you decide whether your child should be running around out school. I'll tell the story about how, you know, last summer in June, when air quality days were significantly poor due to the wildfires in Canada, I mean, I open up my weather app every morning. I can never tell whether or not I should put a jacket on my kids or not. And so I said, oh my goodness, this is crazy. The air quality is really bad. And it was, my kids were supposed to have field day that day outside. And I called my kids' school and I said, I think we should reschedule field day. And they were like, who does she think she is calling? But I'm like, no, seriously, this is bad. Look at the air, you know what I mean? So we have a voice, and they did, they canceled it. One of my friends who's a fellow mom in the school said, did you hear they canceled the field day? I said, yes, I heard. Yes, I heard. But, you know, these are tools that are available to all of us, and we can use it. And not only can we use them for ourselves, we can teach our patients to use them as well to help improve their health. So another important pragmatic step is to really work with our healthcare systems, thinking about how to collaborate to build support systems for our patients and using these program data to really advocate for health at the population level. And a really nice example of this is Tyra Bryant-Stevens, who's at CHOP. She's done a lot of amazing community asthma work. And so she recently published this paper looking at a health system initiated intervention to remediate homes with children with asthma. Basically, they adopted a clinical health worker program. They worked with their hospital system. They integrated this program both from the hospital into the community. And similar to the Healthy Homes program that I described, they were able to make substantive changes within people's homes with the support of the healthcare system, their health system. And they reported improvement in symptom burden among children with asthma as a result of this program. So our institutions where we work can also play a huge role in improving the health of the patients that we serve. And then another great example of this is Elizabeth Matsui. So when she was at Hopkins, she did a study called the Mobility Asthma Project, and they investigated this housing voucher program. So basically the voucher program in Baltimore issued a voucher to allow individuals or families who lived in some of the lowest or highest poverty neighborhoods in Baltimore to move out of those neighborhoods. So this was a natural experiment where she basically looked to see of those families that had children who had asthma and that moved out of their really high poverty neighborhoods, what did that do to their asthma? And so what she saw is after a 12-month follow-up after moving, they identified a 70% reduced rate of exacerbations and almost 60% lower odds of symptom days among those individuals who moved out of those neighborhoods. And what was really striking was that they found that perceived social cohesion, daytime and nighttime safety, neighborhood level safety, urban stress, all of these were thought to mediate anywhere from 30 to 35% of this association between moving out of their neighborhood and an exacerbation. So it really, now I will say that there is some trickiness to this here. Are we saying that everybody who lives in a low income neighborhood should move out of that neighborhood? Maybe not necessarily, but this is strong rationale that the poverty and the neighborhood social factors within those neighborhoods could significantly contribute to asthma. And that was only over a 12-month period of time, so a very short period of time. And lastly, the third sort of category of areas or ways that we can make progress, meaningful progress, is through local and federal advocacy. So collaborating to advocate for change to housing, transportation, education, and really support and education. We need people who are willing to speak up and speak out about this. Most of the people here in this room who are healthcare professionals, we have a voice and we have a level of credibility that not everybody has. And so there's an obligation for us to use that voice for the good of our patients, not just one-on-one on the exam room, but even more broadly than that. And so I just nod to one of the projects that I'm working on right now in Washington Heights neighborhood, nearby where Columbia is located in Washington Heights. And this is the Clean Air Green Corridor project. So I have been collaborating with the school in Washington Heights called the Wheels School. And an environmental science teacher named Jared Fox, who was a teacher at the Wheels School, created this program called the Clean Air Green Corridor project. And basically, New York's, where this school is located and where a hospital is located is very close to the George Washington Bridge, which is the most trafficked bridge in the world. So you can imagine that this contributes to poor air quality in our neighborhood. And so Jared taught his students about this, and he really has been trying to get the students to think about ways that they can advocate for cleaner spaces around their school. And so we've been partnering. So their school is here, Wheels. There are a bunch of other schools that are still on this corridor. They're advocating to pedestrianize this street so that cars and trucks can't pass along this corridor in front of their school. They're planting green trees and trying to make this kind of a pedestrian walkway. And so we've been partnering with them by outfitting them with personal air pollution samplers so that they can measure in real time what their air pollution concentrations are, map this out. Had an undergraduate student create these awesome maps of the children throughout their neighborhoods and where their air quality was high, where their air pollution exposure was highest versus lowest, so that they can take this to their local legislators and use this as rationale to advocate for this pedestrianization of this neighborhood, this area. As mentioned in the introduction, I've also had the privilege of working with the Environmental Protection Agency on 2 committees now. I'm currently serving on the Child Health Protection Advisory Committee, and this is a committee commissioned by the EPA, where we are asked about specific topics that the EPA really wants to figure out. How do health professionals and scientists feel that the EPA can be contributing more to improving the health of children? So we just put together a document on lead safety, and we have others. We did one earlier last year on climate change. And so this is a way that, you know, I can tell you, I never thought that I would be doing work in this space, but you kind of sort of see how the work is aligned in these spaces, and there aren't many pediatricians in those rooms making those decisions. Another great example of that is the Clean Air Scientific Advisory Committee. So I served on the KSAC committee in 2021. And this is a committee, basically what it does is it reviews, the EPA compiles all the scientific literature on a specific topic. For this panel I served on was on PM 2.5. And what they do is they present this information to the scientific leaders, you know, in the field. In that room of, let's say, 20 or so people, there were only 3 physicians. Most were like geospatial chemists and people who are doing amazing environmental science work, but who do not have necessarily the clinical acumen that a clinician would have. 3 physicians, only 1 pediatrician. And so we are helping the EPA determine what are safe levels of air quality within our country. And I'll just show you, this is sort of the trends of ambient air quality standards over time. The KSAC committee that I sat on was in 2021, late 2021, so December 2021. And just this past February, the EPA administrator announced that they're reducing the PM 2.5 annual standard down to 9 micrograms per cubic meter, where it was 12 before. So this is another way that, like, as a physician and as somebody who's passionate about this area, you can make some impact by serving on these committees and really being a voice for our patients and our children. So I've talked to you a little bit today about historical factors rooted in caste and systemic racism that contribute to disparities in social and environmental exposure. We've talked about social and environmental determinants of health and how they contribute to disparities in asthma prevalence and morbidity. And we've spoken about there's so much that we can do by working with our patients, by working with our health systems, and working with legislative and advocacy to address environmental justice. And none of this work could have happened if I alone was the person that was trying to do all of this stuff, all of this work. And I think science, the most impactful science in general, is really a team sport. And so I have to acknowledge our research teams. I've had a slew of mentors and advisors that have really kind of helped shape my career and pushed me into the direction that I'm in right now. I've had a ton of students. It's been so rewarding and fun to engage students, trainees. Last summer, that Clean Air Green Corridor project I told you about, I had a high school student, an undergraduate student, and a medical student basically run that pilot study for us. And so it's been really fun. And I encourage those of you who are in different areas of your training to get involved, because your work can be really meaningful in this space. Of course, we have to thank participants and families, all of our collaborators, all of our supporters, our funding sources. And I'm going to leave you here with this quote by Paul Farmer. There is an enormous difference between seeing people as the victims of innate shortcomings and seeing them as the victims of structural violence. Indeed, it is likely that the struggle for rights is undermined whenever the history of unequal chances and of oppression is erased or distorted. Thank you.